Good morning, everyone. Hope you are all doing well and you are reading well for your upcoming exams. As the time is nearing by, I suppose you are also losing interest in community medicine classes. Nevertheless, this is a subject which continues from your first year right up to the final year. Okay, we shall continue to do small topics of importance, which will be useful to you throughout your medical curriculum and throughout your life also. Okay, so in the same series, we are doing these topics on health education because you know that health education and disease related education for the patients and for their families is very important for any disease management. So half of the let's say management or treatment of disease relies on what kind of health education you provide to your patient and how much they comply with it. Okay, so in this same series, we have told you that what are the channels of communication, what are the various barriers that can be for the communication, and in that barriers, you have understood that cultural barriers, apart from physical barriers, cultural barriers, access to healthcare, and so many things can be important for effective passage of health education from the provider to the recipient. So let us, in the same connection, let us see some of the models and what should be the content of health education for various kinds of scenarios. Because if you just say, let's say a case of anemia has come to you, and you say that after giving iron, folic acid, and everything, you say that. Okay, I have provided health education to the patient, and then you expect suddenly the anemia in the patient to disappear dramatically. But that does not happen in reality because there are so many other things, there are so many socio-cultural, demographic scenarios surrounding the patient that whatever you have said, the patient may not feel comfortable to comply with all that. So it doesn't usually happen with anemia because this is a disease which does not carry so much social stigma along with that. But when you talk about family planning practices, when you talk about reproductive health, when you talk about sexually transmitted diseases, these are diseases or problems which have certain amount of stigma or shame associated with that. And then how do you really convince your patients to change or to follow what you are advising them? So it may not be easy all the time, and that is why for evolution or to address all these problems, various models in health education have been suggested. So the topic that we are doing today, models of health education and contents of health education, usually comes as a small topic, as a short note in your exams, or whenever you are writing about any disease, you can just I would say amplify your answer, or you can make your answer better if you talk about what model of health education is applicable to that particular disease and what contents of health education would be applicable to that disease in particular. So you see, today's talk, it can be borrowed in portions and fitted anywhere into any communicable or non-communicable disease that we talk in detail in the higher semesters. We'll go ahead. Um, Going to the models, you can just note down, or you even have it in your textbooks, the books that you refer back. This has described these models. There are four models basically. First, we will talk briefly about the medical model, motivational model, social intervention model. Okay, first three we will talk about. First is the medical model, as the name implies. Okay, what can be the medical model? That you recognize and you cure the disease. Okay, and there are various technological advances which are available for curing of disease. So every day science is advancing. So today you know certain treatment for a disease, tomorrow some other more effective treatment will come. So you have to advise your patients according to the current medical scenario, and update them with the latest knowledge so that they can make an informed choice about their own health. Okay, so you describe the disease in the biomedical context. You can tell them that what is the pathophysiology of disease and why the disease has happened to you. See, when we talked about sociology, we talked about certain phases of how a person comes to accept that he is suffering from a certain disease. Okay, so if you suddenly tell them that you are suffering from such and such disease, it is not that the person will understand immediately. There are certain phases of which the first stage is denial. So when you tell somebody, even if you take the most epidemic and rampant disease such as COVID, and if you tell somebody that you are suffering from COVID, the first stage usually will be denial. They will say, I cannot suffer from COVID. I have taken all the necessary precautions. Nobody in my family or friends are suffering. My immunity levels are good. I have maintained all the social distancing and hand washing and everything. How can I suffer? So that is the stage of denial. And ultimately then he goes across the internet, talks to his friends, and then he becomes more accommodating to the fact that yes, anybody can suffer from COVID, and maybe then there is a stage of acceptance. So that is why, for not only for COVID but for any disease, particularly for diseases such as leprosy, such as tuberculosis, or let us say for cancers, which have a lifelong impact on the life of the patient, the initial stage of denial can be very, very strong. They usually go into severe depression, and they are in such a state of denial that they tend to talk to various other doctors at this phase. They cross consult, and then finally, when five reputed doctors have said that okay, you are suffering from cancer, then only they read more about their condition and they finally come to terms to accept that. So all these five doctors, it is not only the first doctor but all these five doctors which are confirming the diagnosis of the patient, they need to explain why a certain person can suffer. So they have to explain the entire pathophysiology, entire biology of the human individual, and what are the medical contexts around the individual, so that the person can be suffering, and also offer the avenues for treatment, and they should all match. Otherwise the person may land into more and more confusion and neglect. Okay, the confusion leads to prolonged, let's say, treatment seeking times, because if somebody says something, another person says something, so he has to go to three or four more people to confirm what he actually needs to do. Okay, so that is why in the medical model, very strong belief this is nevertheless the strongest model, but very strong, let's say, emphasis is laid on biomedical views of health and disease. Probably you understood what I am trying to say. Okay, so along with the disease condition, you also offer knowledge about what are the treatment avenues available, what are the technological advances. Let's say for COVID, if you are treating a patient, so you will treat the patient based on evidence-based medicine, and then you will also tell them that yes, a vaccine is about to come, and we will inform you whenever it is available and how effective that vaccine would be, and so many other things. So medical model rests on all these medical facts. Okay, so here, as I told you, dissemination of all the health information is based on scientific facts. So you will share with them what is happening around the world related to a disease. For example, if a mother brings a child with diarrhea, so what is the role of, if you are trying to use the medical model, this is a simple disease, so you will explain why a child can get diarrhea. Okay, and what are the consequences of diarrhea in the child, how it can be life threatening, or how to observe for the danger signs. You will explain everything. So she will first be in the state of denial that why only my child. The child was playing in the same community with five other kids of the same age, they did not get, how could my kid get? And we follow all norms of sanitation and hygiene, so it is not possible. So again, you will explain that this is a simple disease. You will explain the pathophysiology, how any child could get diarrhea and how it can be prevented. And then you, in the treatment part, you could talk about ORS and the wonders of ORS as a life-saving solution. Right. Similarly, for obesity, it is very, very difficult to convince an obese patient to change his diet. So you will explain the risk factor of obesity around the diseases that it causes, and then you can explain how to change the diet and how it might help in reducing the problem. Okay. Similarly, angina, which is caused due to stress. Again, stress is something which is very subjective, and you objectively cannot measure stress. Though there are tools these days, doctors can do it, but normal patients cannot do it. They cannot feel that they are stressed out. So if they are suffering from angina, that is chest pain, repeated chest pain, so you have to explain to them that this could be due to stress, and then help them to identify various surroundings around them which are stress inducing, and as a result they are acting as a risk factor. So all these are based on scientific facts. You can tell them that it is not you alone, there are several other people who are suffering from the similar conditions, and similar kind of risk factors are present around all of us. Okay, so then when you give all this information related to the disease, you provide them all the information related to the technological advances for the advanced diagnostic modalities for diagnosis and treatment. You offer them all the biomedical views, okay, and you provide them scientific facts. So then you expect the people to act accordingly to improve their health. Okay, so it does not happen all of a sudden that you tell that you have COVID and you expect that he will start practicing everything for the prevention and prevention of spread to his close contacts. So you have to invest a lot of energy in explaining the situation to him and then act to take care of the situation. Okay, so this is the medical model. Now, this model comes with some disadvantage, obvious disadvantages, that it places too much emphasis on the medical and pathophysiological and the scientific aspects. But now that you have learned that a lot of disease is caused due to socio-cultural factors, a lot of disease exacerbation or increases in the incidence are due to psychological factors. So this model does not place any emphasis on all these surrounding factors which are equally causative of disease. Okay, second is it does not bridge the gap between knowledge and behavior. So all it does is to provide more and more knowledge rather than trying to identify what behavior of the person might be involved and that might have gone wrong, leading to causation of disease. So it does not talk about all these softer skills or softer attributes of human beings which are contributing to the disease. So as you can see, there is no emphasis on social, cultural, psychological factors. There is no emphasis on behavior change. Okay, so it just offers knowledge, and then we expect that humans will act accordingly. Now, then let us come to the motivation model, and by far the medical model is the most accepted model and the most prevalent model for health education. You will see in your own practice that most of the times for every patient you provide health education based on the medical model itself. Okay, now the second model equally important because you will first let us see what the model is and then I'll explain you how it is important. So this is based on the translation of health information into health action. Okay, so this is one step ahead of the medical model where you are trying to translate whatever information you have provided to the individual, and you are helping the individual to act to control the situation. Okay, so this is the translational model where knowledge is translated into actions. So this is not a very simple act, because if you look at the history, or if you look at the proportion of changes in behaviors that happen as a result of this act, it is hardly less than 1%. It is very difficult to change the behavior of a person in a positive direction. So today, if somebody, let's say students, if you are studying for 4 hours or 5 hours every day, and I ask you to study for 8 hours every day, so you will not listen. You will say that I am already doing enough, why do you want to change my behavior? So to motivate you to study for 8 hours can be quite a task, and I may succeed in doing that, I may fail in doing that, unless circumstances like that are not created. So this is not a simple thing. A person, let's say, again, let's take the example of anemia. A person who is eating well and still suffering from anemia, it is very difficult to explain what is happening in his body. And then if it is really due to nutritional causes, and you tell that even though you are eating too much of rice, but still you are not getting enough iron, it is very difficult to motivate that person to change his diet into an iron rich diet. So motivational model, they talk about all the things surrounding an individual. They identify these kind of factors which can help to translate whatever information you have provided related to the disease condition into health action. So as I told you earlier, there are about 3 stages in adoption which the books have listed. First is awareness of the condition. So the person whom you are educating, he becomes aware of his surroundings. So he knows, he has awareness about his condition, that okay, now I am suffering from this. So that itself leads to some, let's say, sort of curiosity on how can I improve my condition. So this is the stage where motivational messages should be provided. In the awareness stage, it is best to go with the medical model of health education, where you provide more and more information. Okay, and in the second stage, when the person is already motivated, let's say a person is suffering from lung cancer. Okay, so in the first stage itself, when you ask him to quit smoking, he will not do it. He will first be in the stage of denial, and then he will ask everybody whether I am really suffering or not. So he is still in the stage of awareness. So at that point, if you provide him more and more information and educate him about how the disease was caused and how it can be cured, that is okay. Only that much is okay. When he is already motivated to take control of his life, and he does not want his cancer to spread any further, then he is motivated to do everything to stop the spread of the disease. So in this phase, if you tailor your health education messages according to motivation, so that the person is motivated to adopt those changes in life and practice them. Okay, and then finally there is the action stage. So he has actually quit smoking in this stage, and at this part, health education messages should be more supportive, so that he maintains that state for, let's say, a lifetime. Okay, or for a considerable period of time, so that the damages caused to the body might be reversed, if they are reversible. I'm not saying that cancer is reversible, but yes, it can be halted at a certain stage. It may not progress any further if the exposure to risk factor is stopped. So that is the stage of action. And finally there is the stage of awareness. Okay, so in awareness, information of health needs and problems you can provide to make the person more and more aware about what is happening around him, what is happening to him, and what are the avenues available. So most of the public program, they work in this direction, that okay, if you are suffering from anemia, we have the anemia control program, come to us and we will treat you. All these things fall under the awareness part. For the motivation part, there are 3 stages again. Person shows interest and seeks more information. So that means that he is now motivated, and he is willing to probably do what you are going to tell him. Second is evaluation of various aspects of the new idea by consultation. So this is the phase where people would like to cross consult with so many people. If you say you are suffering from COVID, and then they will ask how much is this drug effective, how much is that drug effective. There are so many, no? There are ivermectin, there is hydroxychloroquine, there is.
హలో అరుణిత్ మేడం ఉన్నారా? ఇది యూట్యూబ్ స్ట్రీమింగ్ కావట్లేదండి, కాలేజ్ ఆఫ్ నర్సింగ్ నుండి మాట్లాడుతున్నాను.
రీజనల్ ఫంక్షన్ టెస్ట్ ఒక 10 minutes ఉంటుంది. యాసిడ్ బేస్ డ్రాయింగ్ ఒక 20 minutes ఉంటుంది. 20 minutes దాకా. నేను పైన పెట్టేస్తుంది. మన డాగ్స్ కన్నా ఒకసారి మీ ల్యాప్ ఇవాళ కనెక్ట్ చేసి చెక్ చేస్తారా? యాసిడ్ బేస్ బ్యాలెన్స్ థర్డ్ అక్కడ ల్యాప్ కనెక్ట్ చేయాలి. అరే
can start from streaming I think.
వాళ్ళకి చెప్పారా రెండు ఉంటాయి ఒకదాని తర్వాత ఒకటి అని?
No.
ఇది స్టార్ట్ చేశారా?
Yeah, started.
Good morning everyone. Today's class is renal function test and acid base balance. Now I am starting renal function test. So renal function test, it is used by physical test is where you see the urine, you will test urine. So you measure the urine volume, normally is 1000 to 150 1500 ml per day, and color is pale yellow, normal. Then specific gravity 1.003 to 1.030. pH of urine is normally acidic, it is 4.5 to 6. Odor is aromatic odor in a fresh sample. Now that is urine test. Now this is blood test, routine blood test, an estimation of serum urea, serum uric acid and serum creatinine gives an indication about the excretory function of the kidney. So how the kidney is functioning you will know with the estimation of serum creatinine, uric acid and serum urea. Coming to glomerular function, how the glomerulus is functioning, it is assessed by evaluation of urea, creatinine and inulin clearance test. Creatinine clearance is more specific test for renal function. So how? Tubular function, the concentrating capacity of the kidney gives an idea about the tubular function. Varying quantities of fluid are given to the subject and urine output is estimated. Variation, like you give 1 liter of fluid and estimate the urine output, then give 2 liters, give and estimate urine output, like that. Variation in the urine volume and specific gravity correspond to changes in fluid intake, indicates normal tubular function. Now renal function test, measurement of renal plasma flow and renal blood flow. So then radiological investigations are ultrasonography, where you do ultrasound abdomen and see if the kidneys are normal and ureters are normal and the bladder is normal, or if there are any stones or any strictures, like that. And coming to X-ray, in X-ray you will see normally 90% of the renal stones are radio opaque, you can see them. 10% are radiolucent, where you cannot see renal stones. On X-ray, KUB, that is kidneys, ureters and bladder, you can see if they are normal or any stones are there. Then intravenous pyelography, you give a dye, you inject a dye and see the pyelography, that is kidneys, and the dye is excreted by the kidney, so that it fills the urinary ureters and the urinary bladder. You can see if there is any filling defects or any stones, you can see by intravenous pyelography. Then CT and MRI scanning, you see if there are any tumors or any stones or any defects in the kidney filling, like that, in the CT and MRI scanning. Then they help in to detect the structural and functional abnormalities of the kidneys. I think this finishes the renal function test. No, cystoscopy is there. Cystoscopy is a direct procedure of examination of mucosa of urethra and urinary bladder. Cystoscope is a flexible, narrow tube with a light source. It is introduced into urethra and structures can be visualized as the tube passes through the passage. Biopsy and removal of renal stones can be done using special attachments through cystoscopy. Cystoscopy is useful in detecting cancer of urinary bladder and evaluating obstruction due to enlarged prostate. So these are the functions of cystoscopy. Now coming to normal constituents of urine are inorganic sodium, potassium, calcium and phosphate, and organic constituents are urea, uric acid and creatinine. Others are ammonium chloride, oxalates and minerals. Abnormal constituents are proteins and ketone bodies. Proteins, presence of protein in urine is proteinuria. Appearance of albumin in urine is called albuminuria. Albuminuria is seen in diabetes mellitus and renal glycosuria. In renal glycosuria, glucose is seen. Glycosuria. Glucose is seen in urine. It is called glycosuria. Along with that, in diabetes, proteinuria is also seen. Now, ketone bodies, acetone, acetoacetic acid and beta hydrobutyric acid are called ketone bodies. These are present in urine during uncontrolled diabetes mellitus and during prolonged starvation. Now, bilirubin appears in urine in cases of jaundice. So, blood in urine is seen in diseases of the kidney such as nephritis, and RBC appears in the urine. Now, hemoglobin appears in the urine in conditions with excessive breakdown of RBC. It is called hemoglobinuria. Hemoglobin in urine, hemoglobinuria. In creatine, it appears in urine whenever there is muscle wasting, as in myopathies and starvation. Thank you. So this finishes renal function test. Now we are going to see. We are going to discuss about acid-base balance. Please be seated. Coming to acid-base balance, this is an important topic where you have to understand what is acid-base balance. The pH of arterial blood. What is pH? Negative logarithm of hydrogen ion concentration is called pH. The pH of arterial blood is 7.4. That is, you remember what is an acid, what is a base? Acid is a substance which releases hydrogen ions in solution, and base is a substance which releases OH ions or accepts hydrogen ions in solution. So, this pH is negative logarithm of H plus ion concentration. So, pH varies from 0 to 14. From 0 to 7 or 6.9 it is acid, 7 is neutral, water is neutral, and from 7.1 to 14 it is alkaline base. Okay, acids and bases, acidic, basic. Now coming to the pH of arterial blood, blood plasma is 7.4, that is slightly alkaline. 7 is normal, more than 7 is alkaline. So in a normal healthy individual, the pH of plasma is slightly alkaline, ranging from 7.35 to 7.45. It is slightly less in venous blood, that is, venous blood is more towards acidic, okay, slightly less. It is not acidic, it is basic only, but slightly less basic, okay. The pH of water, even venous blood is also alkaline, but less alkaline compared to arterial blood. The pH of water at 25 degrees centigrade is 7, and the pH of gastric juice is highly acidic, that is up to 2. It is highly acidic. The pH of pancreatic juice is alkaline, up to 8. 8 is above 7, that is above 7 is alkaline. So below 7 is acidic. gastric juice is 2, it is less than 7, so it is acidic. Now pH is the negative logarithm of hydrogen ion concentration. Now increase in hydrogen ion concentration reduces the pH of blood because it is negative logarithm. So as the pH increases, hydrogen ion concentration increases, or as the hydrogen ion concentration increases, pH of the pH decreases. Now the condition is called acidosis. When pH decreases or increase in hydrogen ion concentration, it is called acidosis. Decrease in hydrogen ion concentration of blood is termed alkalosis, and the pH increases in alkalosis. Now the maintenance of a stable hydrogen ion concentration is necessary for life. The molecules that donate hydrogen ions are called acids, while those that remove hydrogen ions from solution are called bases. Bases accept hydrogen ions. Okay? HCl is a strong acid and sodium hydroxide is a strong base. Strong acids and bases can dissociate completely in water. Most acids and bases in the body are weak, that is, hence they release and take up less hydrogen ions. Okay? Strong acids completely dissociate, whereas weaker acids do not completely dissociate, they dissociate very less. The pH of body fluid is stabilized by its buffering capacity. So what is a buffer? A buffer is a substance that can bind or release hydrogen ions in a solution. It keeps the pH of the solution relatively constant even when considerable quantities of acids or bases are added. Suppose there is water. If you add HCl, it becomes acidic. But if there is some buffer in that water, the pH will not change. Or if you add little HCl, pH changes only little towards acidic, but not completely. Okay? Now you see how it happens. Now buffer plus hydrogen ion gives hydrogen ion and buffer. It is a reversible reaction. Here I could not draw the other way, or buffer plus hydrogen ion gives H buffer, that is complex, and H buffer in reverse direction gives hydrogen ion and buffer. Okay, it is a reversible reaction. Increase in concentration of hydrogen ion shifts the reaction to the right, promoting binding of hydrogen to the buffer. So decrease in concentration of hydrogen ion now shifts the reaction to the left, releasing hydrogen ions, thereby maintaining the pH. Okay. Now the main buffers in the body are bicarbonate buffer system and phosphate buffer system, proteins and hemoglobin. Now coming to bicarbonate buffer system. Bicarbonate buffer system consists of two components, a weak acid and a salt. Namely, weak acid is carbonic acid and salt is sodium bicarbonate. Carbonic acid is formed in the body by the combination of carbon dioxide and water in the presence of an enzyme called carbonic anhydrase. Now see this reaction. CO2 plus water gives H2CO3, that is carbon dioxide reacts with water to give carbonic acid. Now this carbonic acid ionizes to form H plus hydrogen ions. So you can see H2CO3 gives HCO3 minus and H plus. Now sodium bicarbonate present in the extracellular fluid, that is outside the RBC in the plasma, dissociates into sodium ion and bicarbonate ion. NaHCO3 gives sodium plus bicarbonate ions. Now, addition of strong acids such as HCl results in the formation of HCl, H plus, which will be buffered by HCO3. So, H plus bicarbonate gives H2CO3, which dissociates to form CO2 and water. It is clear from these reactions that H plus from a strong acid reacts with bicarbonate ion to form weak acid, that is H2CO3, which will not dissociate so easily, and it will not raise the, or it will not decrease the pH. No. HCl reacts with bicarbonate to form weak acid called carbonic acid. Carbonic acid dissociates producing carbon dioxide and water. Thereby, pH of that solution has not been altered much. Now, addition of a strong base such as sodium hydroxide NaOH produces opposite reaction. NaOH plus H2CO3 gives NaHCO3 plus water. So, in this reaction, a weak base NaHCO3 is formed from a strong base. Additionally, bicarbonate is formed. The increase in the blood bicarbonate is compensated by excretion of bicarbonate ion by the kidney, okay, thereby maintaining normal pH of blood. Coming to phosphate buffer system. Phosphate buffer system plays an important role in the tubular function of the kidney. Tubular fluid of the kidney and intercellular fluid. So it will maintain the pH of the intercellular fluid. The components of phosphate buffer system remain in the renal tubule due to poor reabsorption. The phosphate buffer system has H2PO4 minus and HPO4 2 minus. On addition of strong acids such as HCl to this mixture, hydrogen ion will be released from the acid and it will be accepted by HPO4 minus to form H2PO4. HPO4 2 minus, that must be 2 minus to form H2PO4 minus. A strong acid HCl is replaced by a weak acid NaHPO4. So HCl reacts with Na2HPO4, that is sodium hypophosphate, to form NaH2PO4, sodium hydrogen phosphate. So and NaCl. On addition of strong base such as NaOH, OH minus is released is buffered by H2PO4 minus to form HPO4 2 minus. That is, it is accepting one OH, so that it becomes more negative. From minus H2PO4 minus to it is becoming HPO4 2 minus. Now NaOH, that is, if you add base such as NaOH to NaHPO4, and it becomes Na2HPO4 and water. Thus a strong base NaOH is converted into a weak base, causing slight increase in pH, because it is actually slight increase in pH is occurring. If this salt is not there, then pH, or if the phosphate buffer is not there, increase in pH will be greater than what it is happening now. Now, proteins. Plasma proteins are very effective buffers as their carboxyl, that is COOH, carboxyl ion, and amino groups NH3 groups dissociate. They are important buffering systems as their concentration is very high within the cells. So in the cells there are more of proteins. So in the plasma there are plasma proteins. In the cells proteins are more. So coming to plasma proteins which have, that is R is carboxyl terminal, R COOH. COOH is carboxyl terminal, R is what is the carbohydrate chain, and RCOO minus plus H plus. So RCOOH gives RCOO minus plus H plus, and RNH3 gives RNH2 plus H plus. That is carbonic acid or RCOOH, that is COOH is acid, carbonic acid, or COOH acid is giving RCO minus plus H plus, that is hydrogen ion. It is giving means it is a weak acid, and RNH2, that is amino group, he is giving RNH2 plus H plus 1 hydrogen ion it is giving. Okay, now so hemoglobin. Buffering is provided by hemoglobin by the dissociation of imidazole group of histidine residues. So the buffering capacity of hemoglobin is 6 times greater than that of plasma proteins. Deoxyhemoglobin is a weak acid and is better buffer than oxyhemoglobin because of its dissociation capacity. So H plus Hb gives, that is hemoglobin accepts the hydrogen ion to form HHB, that is renal control of acid-base balance. The acid-base balance is maintained by kidneys by secreting acidic or basic urine. The pH of urine depends on the content of acid and base in the extracellular fluid. A large number of hydrogen ions and bicarbonate ions are filtered into the tubules. However, the number of hydrogen ions is more than that of bicarbonate ions. This excess of H plus helps to get rid of non-volatile acid produced by metabolism of proteins from the body. In metabolic alkalosis, HCO3 minus excretion increases, that is bicarbonate excretion increases in metabolic alkalosis. Increase in urine as it is not completely reabsorbed and remains in the tubule. In metabolic acidosis, H plus is excreted. H plus excretion increases and there is complete reabsorption of bicarbonate. In alkalosis, more bicarbonate is released and H plus is retained. Here, opposite is occurring. Thus, kidney regulates H plus ion concentration in extracellular fluid by secreting hydrogen ion and by absorbing bicarbonate. Excess of hydrogen ion in the filtrate is neutralized by phosphate buffer or ammonia buffer and is excreted as a compound of sodium. Uncontrolled renal control of acid-base balance. Uncontrolled, usually commonly in type 1 diabetes mellitus, consumption of methyl alcohol and chronic renal failure and produce metabolic acidosis. So there are 4 types of acid-base disorders. They are respiratory acidosis, respiratory alkalosis, metabolic acidosis and metabolic alkalosis. Respiratory acidosis, where there is more carbon dioxide is retained in the blood because the lungs are unable to breathe properly or take up oxygen and give out CO2, that is that will result in respiratory acidosis. CO2 is retained in the blood, it is not pumped outside, it is called respiratory acidosis. Respiratory alkalosis, where more of CO2 is given away or breathed out. So CO2 content of the blood decreases, resulting in alkalosis. So that the alkalosis is resulting, so that the compensating mechanism is decreased ventilation, so that CO2 is gained in the body and the alkalosis is corrected. Metabolic acidosis and alkalosis is corrected by kidneys, as you have seen. Now, I think this finishes. Thank you.